Let's go back for a second to morphology and calcium. We talked about calcium and making sure that we're assessing for it, but when we're assessing it, what's the algorithm to determine when we need to treat calcium or how aggressively we need to treat the calcium present?
I think we see our bag of tools kind of increasing with options on calcium modification. So I don't want to have a single recipe. A lot of physicians have a different preference of device, but one thing that is a common ground is the ability of a plan NC balloon to fracture calcium, right? And we have a quite good data pointing that at some degree of thickness, even you maxing out your pressure on an NC balloon, that calcium is not going to fracture, right?
Right.
So the next question is what is this magic number? So this magic number is around 500, 700 microns. I'm not suggesting that you need to measure every calcium. Ultron 2.0 is going to give you thickness of calcium, but remember, it's a combination of thickness of calcium and distribution, right? You can have a very thick calcium, but it's just one quadrant, or you still have three quadrants of vessel that is going to expand, right? But the phenotype that requires some sort of lesion preparation is the combination of three quadrants of calcium with thick calcium. How thick calcium? About 500 microns. Then you start becoming concerned. Obviously, there are other elements on this, like on how tight is the lesion. Lesions that are very tight and have this almost circumferential, if not circumferential, thick calcium, for me, it is a clear indication of atherectomy. Because now I know I'm going to start with a small lumen, I'm going to gain enough by debulking this pre. If I don't have a very tight lumen and I have the same amount of calcium, but the original lumen is somehow large for atherectomy device, might be a good application of IVL, for example, right? If I don't have any of those, and the only thing that I have is some calcium in a single quadrant, there is nothing prevent me to direct stent.
So we talked about the thickness and the arc of the calcium. Does length of calcium play into the algorithm at all?
To a certain extent, I try to move away from the magic numbers. There is a well-known rule of 5 that you can adopt. But the way it plays for me is that if I have a substantial length of calcium that require modification, I tend to lean more towards atherectomy versus IVL from a practical aspect of the delivering equipment and interact all at once. If I have something that is very focal, and again, if the lumen is not super critical, stenotic, I might consider IVL.
Calcium is a topic that everyone's always talking about. It's always a challenge in the cath lab. One of the beauties of the Ultron 2.0 software is the AI automatically gives you the arc, the depth, and the length of the calcium in the vessel that you're looking at. When you get that information, how do you assess it after you've interpreted the OCT?
Yes, if I can make an analogy to IVUS, you already mentioned the additional dimensions that OCT is capturing. that is the thickness or the depth of the calcium. I think that's how we should really decide things. It's not only based on arch of calcium anymore, but also the thickness of calcium. So one is due to a pretty sophisticated software on Ultron 2.0 that can automatically detect this, but it's also something intrinsic to OCT, as we discussed on prior episodes, of near infrared being able to navigate through calcium and quantify thickness. This is very important because ultrasound, you're only going to get the superficial reflection and the brightness of the calcium. You really don't know how thick that calcium is. So in my mind, if I'm dealing with 3 quadrants or more, and with thick calcium, and as we mentioned in the past, thick calcium is around 500, 700 microns. This is a situation that you really will not achieve good expansion with standard tools, namely NC balloons, right? So typically my next question is, how tight is the lumen? And if I'm dealing with small lumens and thick calcium and concentric calcium, I'm thinking on atherectomy primarily. If I'm dealing with a relatively large lumen, very thick calcium, very concentric calcium, then I'm thinking on lithotripsy. So this is the separation I made. Another possibility with a large lumen is considering specialty balloons, like scoring balloons, like Coreflex balloon, that combine the ability to fracture with a high pressure NC balloon.
Talk to me a little bit about nodular calcium. That's something I've seen not infrequently. And one of the questions I get is, how do you identify nodular calcium on OCT as compared to thrombus? Because they can look quite similar at times.
Yeah, so very important question, and probably this is the best example we have that a single cross-section interpretation might mislead you. Right, so it's very important when you are in the fence between thrombus, specifically red thrombus, and nodular calcium or eruptive calcium, for you to look at the adjacent frames. So calcium is a continuous, right? So on the adjacent frames, you're going to see calcium being built up and you start protruding in the lumen and losing the fibrotic component. And then you expose a very irregular contour, which now attenuates light as if it was thrombus.
Right.
And sometimes you might even have like a small amount of thin thrombus. But in your mind, you need to know that you are not dealing with a soft tissue there, that it is indeed a calcified plaque.
Right. So if we see calcium then proximal or distal to that area of interest or question,
Right.
then we can be certain if there's calcium present on either side, what we're dealing with is a calcific nodule.
That's correct.
And one of the things, because it's not as common as other types of calcium, when it is present, there are a lot of questions that I get on, well, how do we approach the calcific nodule? What words of advice do you have in your experience, or even how you've seen pre-treatment of a calcific nodule and where it may be, what we should look for in prep, for instance, to know that we're ready to stent the lesion? How can OCT help you there, and what's the strategy?
Yeah, I think if the calcifying node is part of, again, a concentric calcium and a thick calcium around it, I think everything that we just discussed apply equally,
Okay.
right? So a small lumen, you think primarily on a atherectomy device. Bigger lumen, you think about lithotripsy or specialty balloon, scoring balloons. But where more nuance becomes is if you are dealing with an eccentric calcium and it's a nodular calcium. So do you need to do anything about it? And if yes, what? So then what OCT can help you is if it's eccentric and is a relatively large lumen, you really need to understand if your wire bias is gonna allow you to interact with this calcium or not, right? So through the OCT pullback, you know where your wire is, and if it's against that protruding calcium, probably a atherectomy device, either orbital or rotational, could be a proper indication. If you are too far away and is a bigger lumen, you're probably not going to be able to make your atherectomy device interact with that calcium. Then I would follow just a stepwise approach of convention NEC balloon, seeing if you achieve good expansion, and if so, then you can commit with a stent.